Welcome to Nursing 130, Chapter 10, Assessment of the High-Risk Pregnancy. Your book starts out talking about the assessment of risk factors. It breaks it up into biophysical risks, which are factors that originate within the mother or fetus and affect the development or functioning of either one or both. The psychosocial risks include the maternal behaviors and adverse lifestyle. The socio-demographic risks arise from the mother and her family. And the environmental risks can include any teratogens or environmental substances that can affect fertility and fetal development. To start with the biophysical risks, I'd like you to look at box 10.1 on page 250 in your text. The heading reads Categories of High-Risk Factors. The biophysical factors are broken down into genetic considerations, which are genetic factors that may interfere with normal fetal or neonatal development. Nutritional status, these are conditions that influence the nutritional status, such as young age, 3 pregnancies in the previous 2 years, tobacco, alcohol, or drug use, inadequate dietary intake because of chronic illness or food fads, inadequate or excessive weight gain, and a hematocrit value of less than 33%. And then we have medical or obstetric related illnesses such as poorly controlled diabetes or hypertensive disorders. Some conditions that put the woman at risk are also included in box 10.2 on page 251. Some of those conditions listed are polyhydramnios, oligohydramnios, intrauterine growth restriction, such as better known as IUGR, some of the maternal causes and the fetal placental causes, and then chromosomal abnormalities. Next, I'd like to talk about the psychosocial risks. These are disturbed interpersonal relationships, emotional distress. The patient may have inadequate social support, have unsafe cultural practices, or have substance abuse problems. It also includes smoking, which has a cause and effect relationship between maternal smoking and reduced birth weight. It results in low birth weight infants, higher neonatal mortality rates, increased rates of miscarriage, and increased incidence of premature rupture of membranes. These could be aggravated by low socioeconomic status, poor nutritional status, and the concurrent use of alcohol. Caffeine, women who consume caffeine daily, the equivalent of up to about 12 ounces of coffee per day, may be at increased risk for miscarriage or giving birth to infants with IUGR. Alcohol exerts adverse effects on the fetus as well. We know about fetal alcohol syndrome. The newborns or children can have learning disabilities and can be hyperactive. In regards to drugs can negatively affect the developing fetus. These can include medications prescribed by the healthcare provider or bought over-the-counter, commonly abused drugs such as heroin, cocaine, and marijuana, as well as the new suburban drugs such as Vicodin and things like that. We're seeing a great impact in the neonatal intensive care units with those. In regards to psychological status, childbearing can trigger profound and complex changes in a woman's lifestyle. These evidence to suggest a relationship between emotional distress and birth complications. In regards to socio-demographic risks, we have the low-income pregnant women. These women also don't get prenatal care right away, which results in failure to diagnose and treat complications early. They might not be coming to the hospital or to prenatal care for reasons of financial, where they live, all sorts of different issues can play into that. In regards to age, we have the young adolescent as well as the older mother. These in and by themselves aren't the only problem, but they seem to have other physiological and psychological risks that need to be evaluated as well. Adolescents who are most at risk are young girls who are less than 15 years old. Some of the complications that they might see are anemia, preeclampsia, a prolonged labor, a contracted pelvis, encephalopelvic disproportion. That's where the baby won't fit coming through vaginally. Some of the long-term social implications of early motherhood are lower educational attainment, lower income, increased dependence on government support programs, high divorce rates, and a higher parity. For mature mothers, they might suffer from some conditions such as chronic hypertension, preeclampsia, diabetes. They may have prolonged labor. The birth may result in a cesarean birth. They might have placenta previa, placental abruption, and possibly death. Her fetus is at greater risk for low birth weight, or macrosomia, especially with the diabetes, chromosomal abnormalities, congenital malformations, and neonatal death. Parity, or the number of previous pregnancies, are a risk factor that's associated with age and includes all first pregnancies, especially a first pregnancy at either end of the childbearing age continuum, meaning a young adolescent or an older woman. They're both going to be at higher risk the first time they're pregnant. The incidence of preeclampsia and dystocia, which is like a difficult labor, is increased with the first birth. In regards to marital status, the increased mortality and morbidity rates for unmarried women are higher. Their increased risk includes preeclampsia and are often related to inadequate prenatal care and a young childbearing age. Residence, the availability and quality of prenatal care can vary widely with geographic residence. Women who live in metropolitan areas are more often having visits than those who live out in the country or in rural areas who can't get into the healthcare agency. And ethnicity, although ethnicity by itself is not a major risk, race is associated with some poor pregnancy outcomes. Non-Caucasian women are more than 3 times as likely as Caucasian women to die of pregnancy-related causes. African American babies have the highest rates of prematurity and low birth weight, and the infant mortality rate among African Americans being more than double that of the Caucasians. And lastly, the environmental factors for high-risk issues are hazards in the workplace, such as chemicals, anesthetic gases, radiation. These are all teratogens that we talked about before at the end of Chapter 6. Teratogens are the environmental substances or exposures that result in functional or structural disabilities. They include drugs, chemicals, infections, exposures to radiation, certain medical conditions such as diabetes and PKU. Also, environmental factors include infections, and like I mentioned, the drugs and environmental pollutants as well. Psychological considerations. These women who are labeled high risk, they may be feeling a sense of vulnerability. They may have stress related to the diagnoses, ambivalence regarding the pregnancy, the inability to accomplish the tasks of parenthood, and they might be fearful for the well-being of the mother. Now I'd like to talk about antepartum testing for the high-risk pregnancy. Some of the testing measures we're going to be doing are the fetal movement or kick count, ultrasound, nuchal translucency screening, biophysical profile, MRIs, Doppler flow studies, amniocentesis, chorionic villi testing, PUBs, alpha-fetoprotein, the maternal quad test, fetal heart rate monitoring, non-stress test, including the vibroacoustic stimulation and contractions stress test. There's 2 major goals when we're talking about antepartum testing. The first is to identify the fetuses at risk for injury caused by acute or chronic interruption of oxygenation, so permanent injury or death might be prevented. The second goal is to identify appropriately oxygenated fetuses so unnecessary interventions can be avoided. Again, your textbook breaks them up into different types of assessments, and starting with the biophysical assessment, we have the fetal kick count, the ultrasound, and the MRI. The fetal movement or kick count, there's several versions of the kick count sheet. One is included in your text. Often the OB clinics and the doctor's offices have their own, but generally beginning at about 18 to 20 weeks, there's several different protocols in place. You can do them once a day for 60 minutes. Some physicians or midwives prefer 2 to 3 times daily after meals or at bedtime for 2 hours or until 10 movements are felt. And then another is all fetal movements in a 12-hour period until 10 movements are counted. If less than 3 movements in 1 hour, we may need further assessment on this fetus. But fetal movement is a gross indicator of fetal well-being. It's simple, useful, it's not expensive, it can be done at home. The important thing you need to know that sometimes babies sleep, and so we need to avoid their sleep patterns. So initially they may have, if the baby's sleeping or they haven't felt movements in about 20 to 30 minutes, they may have the mom jiggle her tummy or something or move around to try to get the baby to wake up a little bit so they can feel that movement. But the goal is fetal movement, and it's a reassuring sign of fetal health. Again, remember to instruct your patients to report less than 3 movements per hour, or sometimes over a 12-hour period. If there's been no fetal movement that the mom's noticed, then that's something that needs to be investigated further. But it's used in with complications involving fetal oxygenation. The next test is called an ultrasound. In the ultrasound are high-frequency sound waves that are beamed onto the abdomen. The echoes are returned to a machine that records the fetus's location and size. It's used in the first trimester basically to determine the number of fetuses, to see if it's a twin or triplet or whatever gestation. The presence of fetal cardiac movement and rhythm is looking for uterine abnormalities and for gestational age. In the second and third trimester, it's used to determine fetal viability and gestational age, if there's any size date discrepancies, amniotic fluid volume, the location and the maturity of the placenta, the uterine anomalies or abnormalities, and also with the results for an amniocentesis. With fetal heart rate activity, it's apparent as early as 6 to 7 weeks gestation. When they're talking about fetal maturity for gestational age, they're looking at the biparietal diameter. That's a term you may or may not have heard. That's a head diameter, and then the length of the femoral bone. And they're actually trying to differentiate between wrong dates and true IUGR. Sometimes babies are just small, but they're actually further along in gestational age. So the younger or the earlier the ultrasound, the more accurate it is in relationship to the gestational age. They're also going to try to visualize some fetal abnormalities, and the next slide will show some of those. Placental position and function. They're going to grade the placenta. As the placenta gets more mature, they're going to notice some calcifications and things. And they're also looking for amniotic fluid volume. They're looking for pockets of amniotic fluid, and they're using that measurement in a test we're going to talk about in a few minutes called the biophysical profile. So for nursing care, you need to instruct the woman to drink 3 to 4 glasses of water prior to coming in for the examination and not to urinate. When the fetus is very small in the first and second trimesters, the client's bladder must be full during the examination in order for the uterus to be supported for imaging. A full bladder is not needed if the ultrasound is done transvaginally instead of abdominally. So there's 2 types. There's a transvaginal, which is good for pelvic anatomy, and then the transabdominal, which is good for dates, growth, and structures. So you want to position the woman with pillows under her neck and knees to keep pressure off the bladder. Late in the third trimester, you're going to want to place a wedge under the right hip to displace that uterus and to prevent supine hypotension. So you want You can also just think about the mom too. She's probably nervous or excited, but you're going to position the display so the woman can watch if she wishes. And right afterwards, you're going to want to make sure you have a bedpan or a bathroom immediately available. There's not any known complications, but there is some controversy over how often we should routinely be using ultrasound. Nuchal translucency screening is basically an ultrasound in the fetal neck area. It's looking for subcutaneous accumulation of fluid, and it's associated with Down syndrome. It's done in the first trimester, around 11 to 14 weeks, with a follow-up to earlier detection of fetal chromosomal tests. The Doppler flow measures the velocity of the blood flow. It's looking at the red blood cells as they travel through the blood vessels. It's good for women with diabetes and hypertension. It assesses placental insufficiency and can assess the number of nutrients getting to the fetus. It's looking at blood flow in the umbilical vessels as well as the aorta and brain. It's non-invasive and has no contraindications. To what extent the maternal disease is impacting the fetus is something that we want to look at, and the fetal well-being is better suited outside rather than inside the uterine environment. If they're looking at decreased circulation and uterine placental insufficiency, that means that the baby's not getting enough oxygen, not getting enough growth because of some vascular changes that are going on, and this baby might actually do better outside of the womb instead of inside. But those are some of the things they're trying to ascertain as they're looking at that Doppler blood flow. Magnetic resonance imaging, or an MRI, is non-invasive. It's similar to computed tomography, or CT. It provides images of the soft tissues and the vascular structures without the ionizing radiation of a CT. The MRI examiner can evaluate fetal and maternal structures, the placenta, the amniotic fluid, the biochemical status of tissues, and the organs, as well as other anomalies. It takes about 20 to 60 minutes, and the mom must lie still. They may give occasional breaks during that time, but the fetus sometimes interferes with the MRI because it moves around, and the only way to truly control that is they may need to sedate the mom, which will then sedate the baby and keep the fetus from moving. But they're definitely going to weigh that out and only sedate the mom if they absolutely need to get an accurate assessment on the baby. The next type are biochemical assessments, and that's going to be the amniocentesis, the chorionic villus sampling, percutaneous umbilical blood sampling, also known as PUBS, and maternal assays. So an amniocentesis is it's basically a transdermal puncture of the amniotic sac, and we remove amniotic fluid sample from the uterus. It's used to determine fetal genetic diagnosis, usually in the first trimester, fetal lung maturity in the last trimester, and fetal well-being. We only perform it when the uterus rises above the syphysis, so between 12 and 13 weeks, and the amniotic fluid is formed. So you're going to want to make sure the practitioner has an accurate fundal height assessment before they perform this procedure. It usually takes about 10 days to 2 weeks to develop cultured cell karyotypes, and remember we talked about karyotype screening and as part of the genetic testing that we do on patients that they suspect have congenital anomalies. So because it takes up to 10 days to 2 weeks to get back, it could be well into the second trimester before the diagnosis is made, making the choice for abortion more dangerous. The findings for genetic disorders, the karyotype determines Down syndrome, which is trisomy 21, and other trisomies, and the sex chromatin or X-linked disorders. The biochemical analysis part determines more than 60 types of metabolic disorders, including things like Tay-Sachs. Alpha-fetoprotein in the amniotic fluid, elevations may be associated with neural tube defects. Low levels may indicate trisomy 21. It also is looking in the last trimester or the third trimester, it's looking for fetal lung maturity. So that's called the LS ratio, or the lecithin sphygmomyelin ratio. And a ratio of 2 to 1 indicates fetal lung maturity, unless the mother's a diabetic or has Rh disease or the fetus is septic. The LS ratio of 2 to 1 and the presence of PG, or also known as phosphatidylglycerol, most accurate determination of fetal maturity. The PG is present after 30 weeks of gestation. So lung maturity is the best predictor of extrauterine life survival. In terms of developing fetal well-being or looking at fetal well-being, there's a test called bilirubin delta optical density, or OD assessment, and that should be performed in the mother previously sensitized to a fetus Rh positive red blood cells and having antibodies to the Rh circulating cells. The delta OD test measures the change of the optical density of the amniotic fluid caused by staining with bilirubin. It's done around 24 weeks. And we will talk about that a little bit later, about the Rh incompatibilities. Meconium in the amniotic fluid may indicate fetal distress. Often when babies are stressed out, that's when they have bowel movements. Nursing considerations. Prior to the amniocentesis, we're going to get a fetal heart rate tracing and get the baseline vital signs and see what the fetal heart rate is. Remember, normal is 110 to 160, and depending on how early in their pregnancy, the earlier in the pregnancy, the higher the fetal heart rate, because of the more sympathetic or speedy involvement of the autonomic nervous system. The more mature the baby is, even going towards post-dates, that lower that fetal heart rate is, closer to the 110 level. We're going to want to get about a 20-minute recording of the fetal heart rate. We're going to place the patient in a supine position with hands across the chest. If prescribed, they may shave the area and scrub with an iodine or betadine. They're going to draw a maternal blood sample for comparison with post-procedure blood samples to determine maternal bleeding. We're going to provide emotional support, explain the procedure. You never want to leave the patient alone during this. We're going to label the samples if the bilirubin test is prescribed. You're going to darken the room and immediately cover the tubes with an aluminum foil or use opaque tubes. After the after the specimen's drawn, you're going to wash the abdomen, assist the woman to empty her bladder. A full bladder can irritate the uterus and cause contractions. In post-procedure, we're going to monitor the fetal heart tones for a good hour and assess for uterine contractions and irritability. We're going to instruct the woman to report any contractions or changes in fetal movement or fluid leaking from the vagina. The complications are there. It's about spontaneous abortion, but it's only in about 1% of the cases, and there is a chance of fetal injury if that needle, when it was punctured through, hit the baby or the cord or the placenta, and there's a risk for infection. And a HESI hint that they're talking about is when the amniocentesis is done in early pregnancy, the bladder must be full to help support the uterus and to help push the uterus up in the abdomen for easy access. When an amniocentesis is done in late pregnancy, the bladder must be empty so it will not be punctured. And this is a picture of the needle going in. It's generally done under ultrasound guidance. They're going to aspirate that amniotic fluid when they get it. It's normally the color of water. For fetal lung maturity, just to review, the LS ratio of 2 to 1. And the LS is the protein components of surfactant, which is indicative of lung maturity. Okay. The next thing we're going to talk about is chorionic villi sampling. And that is removal of chorionic tissue. It's a small piece of the villi during the period between 8 and 12 weeks it's gestation under ultrasound guidance. It cannot replace amniocentesis completely because there's no sample of amniotic fluid which can be obtained for the alpha-fetoprotein or the Rh disease testing. But it can be done earlier, and that has specific benefits when it comes to evaluating whether perhaps they're going to terminate the pregnancy, because those results will come back quicker. But just to refresh your memory, the chorionic villi are the little finger-like projections that cover the embryo and anchor the placenta to the uterine lining. So they're going to remove the chorionic tissue. They're going to go in with a needle and they're going to pull back a little bit of that tissue. They're looking for chromosomal disorders or enzyme deficiencies. They're going to be able to tell the fetal gender and any sex-linked disorders or X-linked disorders. And it's a little more accurate than some of the other tests. Like I mentioned, it's done earlier, 8 to 10 weeks. There's a risk though if it's done too early, because we're talking right now about 8 to 10 weeks. But remember, when you're talking about when the organs form, when the limbs form, that's right around that 7th to 9th week. So if there is a risk that it could cause some limb abnormalities during that important fetal development time, during that crucial embryo stage. Rh negative mothers are at risk of isoimmunization because if the baby's Rh positive, that can transfer through because of the direct entry into the chorionic villi. It doesn't really test for spinal cord or neural tube defects, but it can test for Down syndrome and other genetic disorders. So for nursing care, have an informed consent signed before any procedure. They're going to place the woman in the lithotomy position using stirrups. You're going to warn her that there might be a slight sharp pain upon the catheter insertion. And again, I've seen some statistics that say 1% chance of a spontaneous abortion up to 5% chance of abortion. So you're going to want to definitely monitor her for contractions, leaking, those kind of interventions. And here's a picture of it where they're doing a real-time ultrasound. They're looking for maternal tissue, and they're going in with that little catheter and they're aspirating part of that. And you can see the speculum is inserted in the vagina as well to help support the posterior wall so they can get the catheter threaded through the cervix. Percutaneous umbilical blood sampling, better known as PUBS, is an interesting condition. It's when they're actually going in under ultrasound guidance again, and they're going to, instead of going into the amniotic fluid, they're actually going right into the umbilical cord, and they're withdrawing umbilical fluid. Who are they going to do this on? Any fetus who they believe has a blood disorder or anemia, and they actually can do blood transfusions. They'll withdraw blood, they'll test it, and they'll possibly transfuse, and this has prolonged these babies that normally would have died in utero early on in the pregnancies. They might do direct Coombs, fetal blood type, complete blood count, an assessment and the treatment of isoimmunization. They might do prenatal diagnosis of inherited blood disorders such as hemophilia A or detection of a fetal infection. And they might give, like I mentioned, intrauterine blood transfusion, which I've witnessed on several occasions, and it's quite a procedure. We used to do it at Hurley when we had our perinatologist there, and the work involved and the timing and monitoring the mom before and after the procedure was very time intensive and a little bit nerve-wracking, actually. But our physician was very good at it, and we saved a lot of babies' lives and got them to a healthy age of gestation where they were viable and they could live outside the womb. So it was a really wonderful thing to witness. And that's a picture of the needle being with ultrasound and the needle going into the umbilical cord and aspirating the blood and then possibly even transfusing it back in. Maternal assays, one of the ones we want to talk about is the maternal alpha-fetoprotein, maternal serum alpha-fetoprotein that's found in the maternal blood. Okay, and in early testing they're looking for genetic issues. The second, if they find that that's abnormal, they may go ahead and do an amniocentesis, and then they'll actually evaluate those a little bit more thoroughly through the amniotic fluid, which is going to be a more definitive test if there are chromosomal or other issues, neural tube defect issues. So when it's in the blood, it's called the MSAFP, or maternal serum alpha-fetoprotein, and when it's in the amniotic fluid, it's just the alpha-fetoprotein. But alpha-fetoprotein is actually a substance produced by the fetal liver. If the results come back high, it's linked to neural tube defects. If it comes back low, it can be linked to chromosomal or Downs. It has a lot of false positives as well as false negatives. So that means that someone will get a result in the maternal serum alpha-fetoprotein that says that their results are low. So they're nervous their whole pregnancy, and it's just they're just very stressed, but then it turns out nothing's wrong. But you also get negatives where it says it's negative for any alpha-fetoprotein, everything looks great, it's in the normal healthy range. Then that shows us that, and then all of a sudden the baby's born with Downs or with a neural tube defect that it didn't pick up. So there are some controversial issues or ethical issues, as I think we might have mentioned in class, that some women prefer not to have it done, or some families prefer not to have it done. But it's done generally around maternal serum alpha-fetoprotein peaks, or it's detectable, I should say, in the serum around 12-13 weeks, and it goes up until 32-34 weeks. Okay. And then to add to that, there's the quadruple test, which is the alpha-fetoprotein, the estriol, human chorionic gonadotropin, and inhibin A. These results are affected by maternal weight, gestational age, and multiple pregnancies. Abnormal results are followed by amniocentesis and ultrasound. The screening can be done anytime after 12 weeks. Around 14 to 22 weeks, and each textbook says it a little bit different, is the best time. It's reported to detect 85% of all Down syndromes. The quad screen test is a maternal blood screening test that looks for 4 specific substances, as I mentioned a minute ago. So the alpha-fetoprotein, that's the protein that's produced by the fetal liver. The HCG, or the human chorionic gonadotropin, is a hormone produced within the placenta. It preserves progesterone that maintains the pregnancy, and it maintains the endometrial lining. The estriol is an estrogen produced by both the fetus and the placenta. It should be decreased with pregnancy, but increased levels cause uterine contractions. Inhibin A is a protein produced by the placenta and the ovaries. Then there's antepartum testing or assessment using electronic fetal monitoring. The first one I'd like to talk about is non-stress test, and then we'll talk a little bit about vibroacoustic stimulation and contraction stress test. The non-stress test, or the NST, measures the response of the fetal heart rate. It's used to determine fetal well-being in high-risk pregnancies and is especially useful in post-maturity. It notes the response of the fetus to its own movements. When you and I are standing still, or when we go to make a big movement, our heart rate usually goes up. Well, that's what we expect the fetus to do in utero as well. So we're measuring for those fetal movements, and what we want to do is have the mom press a little monitor to tell us that when she feels a movement, and we're going to correlate that to see if the baby's accelerating. A healthy fetus will usually respond to its own movement by means of a fetal heart rate acceleration of 15 beats lasting for 15 seconds after the movement, twice in a 20-minute period. So as we're looking at the fetal monitor tracing, remember the normal fetal heart rate is 110 to 160. So we're looking at a baseline Usually it's around 10 beats or so, like 120 to 130 or 130 to 140. And then we're looking for with an acceleration, that's anything that goes above the baseline. So we're looking for one that goes about 15 beats above the baseline, and it lasts for about 15 seconds on the fetal monitor tracing. We're looking for 2 or 3 of those accelerations, and they need to last about 15 seconds long. The fetus that responds with a 15 beat acceleration by 15 seconds is considered reactive and healthy. A non-reactive test is when it falls short of that. Now, on a premature baby around 32 weeks, because they're not fully mature, it's acceptable to have a 10 beat acceleration lasting 10 seconds. That's considered a reactive test. But under normal circumstances in a baby that's above 32 weeks, we're generally looking for a 15 by 15 acceleration. So without that, no acceleration of the fetal heart rate, they'll even run the test a little bit longer. So they say 15 to 20 minutes long, but they'll run it longer. Sometimes babies sleep, and during that time of sleep they don't have accelerations. So they might try to stimulate the baby with the vibroacoustic stimulation, and that's a little ultrasound wave that causes a vibration, and it kind of, if you think of the startle reflex or the Moro reflex in a baby, it's going to shake, it's going to vibrate, and it's going to cause the baby to move, like in that startled response. And so that sometimes, remember I said the fetal movement is often correlated with a fetal acceleration of the heart rate. So no acceleration, they're going to take into consideration and probably do more testing on this baby and monitor it more closely. So the OB non-stress test, three negatives in a row to interpret results of a non-stress test. N is for non-reactive, non-stress is non-good, or is not good, I should say. Now the contraction stress test is a oxytocin challenge test. It's not done very often anymore, honestly. I rarely see it. It's a test for the fetal response to labor. So if we were concerned that this baby wasn't going to tolerate labor, they might, and they have done in the past, contraction stress test. The fetus is challenged with the stress of labor by the induction of uterine contractions in the fetal response to physiologically decreased oxygen supply during uterine contractions. Remember, the uterus is a big muscle. It has all those blood vessels, so when those blood vessels constrict or tighten down on that, it decreases the blood flow to the baby. So we want to see under that stressful condition how the baby's heart tones handle it, how the baby handles it basically. So we're looking for fetal well-being. There's different ways to induce contractions. One is nipple stimulation, or they can infuse a dilute IV solution of oxytocin or pitocin, as you might know it as. An unhealthy fetus will develop what we call non-reassuring fetal heart rate patterns in response to uterine contractions. Late decelerations are indicative of uteral placental insufficiency, and that's not a good sign. So nursing care, we're going to assess for contraindications such as prematurity, placental previa, hydramnios, multiple gestation, and previous uterine classical scar, rupture of membrane. So they don't want to induce labor on any of those kind of conditions. They're going to place external monitors on the abdomen for the fetal ultrasound monitor and the tocodynamometer, which measures the contractions. They're going to record a 20-minute baseline strip to determine the fetal well-being or the reactivity or the presence or absence of contractions. To assess the fetal well-being, a recording of at least 3 contractions in 10 minutes must be obtained. If nipple stimulation is attempted, they're going to have the woman apply warm, wet washcloths to the nipples and roll the nipple of one breast for 10 minutes. They're going to begin rolling both nipples if contractions do not begin in 10 minutes. Then they're going to proceed with the pitocin or the oxytocin infusion if they're unsuccessful with the nipple stimulation. A negative test suggests fetal well-being, so it's kind of the opposite. No fetal heart rate decelerations is a good sign. That's a negative test. A positive sign is late decelerations, or negative. It's a negative outcome is a positive. It's declared positive. So if you have late decelerations, which represents uteral placental insufficiency, and when we get into fetal monitoring, when we talk about normal labor, we'll talk about some of these late decelerations. But if you have those present with at least 50% of those contractions, it's considered a positive test, and that's probably a baby that's going to end up getting a cesarean section because it can't tolerate labor. But now, like I mentioned, it's generally replaced by the biophysical profile. I don't see it done very often, but it is noteworthy in case you do happen to come across it in the clinical setting. So this is an example of a fetal heart rate tracing for a non-stress test. And you can see all the squiggly lines. It looks like this baseline is between 120 and maybe 135. And when it goes up to 180 or it goes up to 160, and another part towards the end of the strip it goes up to like 170, those are all accelerations. And each of these little tiny squares are 10 seconds. So when we want it to be 15 seconds long and then 15 beats above the baseline. And it definitely is in this. This is called a reactive non-stress test, which is a healthy sign, and it tells us that the baby's doing well. Now this would be considered a non-reactive stress test, because if you'll notice, the baseline is anywhere from 140s to 150s, but we don't really see any accelerations that last any length of time. So this would be considered not so healthy sign. They're going to follow up with more frequent non-stress tests. They may reposition the mom. They may feed her in case her blood sugar is running low. They maybe make sure she has some IV fluids on board. And perhaps the baby's just sleeping, and so they may try to do some stimulus to the baby with movement or vibroacoustic stimulation. The biophysical profile is it's ultrasound, and it's used to evaluate fetal health by assessing 5 variables. The 5 variables are fetal breathing, the gross body movements, which we're looking for 3 movements, fetal tone, that's how much the baby contracts its arms up and legs and moves around, the reactive fetal heart rate, like for that you do non-stress test, and then the amniotic fluid volume. So we're looking for pockets of amniotic fluid on the ultrasound, and we want them to be larger than a centimeter, and we want them to have at least 2 or more of those 1 centimeter pockets. Anything above that is fantastic. But each variable receives 2 points for a normal response and 0 points for an abnormal or absent response. So if we're looking at the NST, that's telling us the non-stress test, and if it's reactive, if we have those 15 beat by 15 second accelerations, that's going to be called a reactive fetal activity study or fetal non-stress test, and that's going to get 2 points. The fetal breathing, we're looking for they actually can see the baby suck the fluid in. They're looking for just a little bit, and my next slide will show some of those parameters. So you get a score of 2 or you get a score of 0. In the nursing care, you're going to prepare the client for the procedure, inform the client or patient the purpose of the examination. You're going to provide psychological support, especially if testing will continue throughout the pregnancy. Again, a lot of these high-risk conditions, they start doing this midway through the pregnancy and they continue throughout the pregnancy. You're going to advise the client that a low score indicates fetal compromise that would warrant more detailed investigation, and a score of 8 to 10 indicates fetal well-being. That's our goal. Now, sometimes they'll do a biophysical profile, but they won't do the non-stress test because they'll just do the ultrasound at the bedside, and they don't have the full amount of time, or they don't have the resources to do that. So they may drop that part off, but and that would be a total score of 8 instead of 10. But that, again, sometimes that's done at Hurley, I noticed, and I'm not sure if it's done at Genesis or not. So this is a cute little picture assessment test for fetal well-being, and as you see on the right side is the biophysical profile, or the BPP. It's the first choice for follow-up for fetal evaluations. We talked about the fetal breathing movements. They're looking for 1 episode of breathing in the 30 seconds in a 30-minute period. Remember, babies aren't breathing in oxygen, but the lungs do have some work. The fetal tone, at least 1 episode of extremity extension and flexion. We're looking for body movement, 3 episodes in that 30-minute period. Amniotic fluid volume, again, as I mentioned, more than one pocket of greater than a centimeter in two planes. And then the non-stress test, we want a reactive non-stress test. We want fetal heart rate is increased with activity, and each total score of 10, each criteria has a possibility of 2 points.